Alright, good morning everyone. Bright and early. Thank you Raji for having me on this course, and good morning ladies and gentlemen. Well, I'm going to talk about something that is a little outside what we normally have in corneal diagnostics. It's the new kid on the block, so to speak, and it relates to an aspect of the cornea that is hitherto not very well explored. We've always suspected and talked about ocular rigidity and scleral rigidity, but we've never really thought how important it actually is and how much variation there can be in various parameters. So there is clinical tools now that are available to us, and they create a certain data about the way the cornea behaves biomechanically, and this kind of a graph that these machines create is called a biocorneogram. Just like a ECG, it creates a graph like this, and I'm going to talk about this. There's no financial disclosure. This is the machine. It's actually a fancy non-contact tonometer with an analytical software and a computer attached, and it gives us various parameters. Do we have a pointer? It gives us various parameters like the IOP-G, which is the IOP Goldman, because all NCTs in the end are calibrated to the Goldman tonometer, and it gives us a correlated IOP, which is the corneal compensated intraocular pressure. It also gives us two biomechanical factors called the CRF, or the corneal resistance factor, and the corneal hysteresis, and we have a pachymeter attached to it which can give us the central corneal thickness as well, but that is independent of all this. So it actually gives us 5 parameters. Now this is the kind of signal that it creates. Now basically what happens is, in a non-contact tonometer there is an air puff that hits the cornea, and as the air pressure goes up, the cornea gets flatter and flatter till it reaches a point where it becomes absolutely flat. And at that point there is a signal that is also being projected on the cornea. The signal achieves maximum intensity on reflection because you have a flat applanated cornea which works like a mirror and reflects the signal, so you have a peak. That is your applanation pressure in, as the pressure on the air pressure side is going up. Normal non-contact tonometers will stop measuring once they have achieved this, and the air pressure immediately falls off, and that's the end of the whole analysis. But what this machine does is it continues to give pressure, thereby it makes the cornea concave, and then as the pressure starts to come down, there is another phase when the cornea becomes flat or becomes applanated, which it calls the out pressure or applanation pressure 2, or the out signal peak, before the cornea returns to its normal state. And all this happens in about 20 milliseconds. So it's very quick, and just like a normal NCT, but it creates an applanation pressure 1 and an applanation pressure 2, and the difference between these two is what they call the corneal hysteresis. So these are this kind of signals that it gives, and other than the values, it also tells us about the peak amplitudes and widths, as well as aspect ratios, the up-down slopes. There are lots of parameters which I'll talk about as well, which this machine analyzes before giving us certain values. Now, how do these things get created? You know that the cornea is a viscoelastic material, and it has the behavior to deformation is like an automotive strut assembly, or the shock absorbers that we have in automobiles, and it has a spring element to it and a gas filled element to it, or a viscous element to it. Now the static resistance or elasticity is directly proportional to the stress, that is the applied force, and is independent of the length of the time or the rate at which the force is applied. That means if you press a spring, the resistance that in that pressure is independent of the force being applied or the speed at which it is being applied. But when you talk about viscous damping, this is the resistance to an applied force, depends primarily on the speed at which the force is applied. So the faster you apply the force, the more is the damping effect. And it is a combination of these two physical characteristics that create a viscoelastic system, which is what the cornea actually is. So these are the definitions of the hysteresis laid down many years ago, of how how a property of a physical system that does not follow the forces applied to them instantly but reacts slowly, and also does not return completely to its original state instantly. When we look at the signals thrown up by these machines, you can see that in the normal signal there is a close relation between the CH and the CRF. Raw signal has nice clean peaky points. It has similar amplitudes on the in and out sides, and the raw signal is fairly smooth with hardly any bounce. The baseline signal is also flat and has the same amplitude. When we look at keratoconus, see what happens. The whole thing gets truncated. The IOP-CC is higher than the IOP-G. There are low CH and CRF values. There has low amplitude peaks. There are sharp thin peaks like a bounce in the signal as it comes down to the bottom. The signal here is showing that that same bounce that I'm talking about, and it's also very noisy. That means there's a lot of flutter in this cornea. In a subclinical keratoconus signal, the signal is somewhere halfway between normal and keratoconus, and here again the IOP-CC is higher than the IOP-G, with the CH and this just below the normal range, and the CRF also below the normal range, and there is a raw signal bounce as well. These are the other ORA waveform patterns that are looked at, and the parameters. There are 37 of these which have been independently analyzed to give what we call the corneal signature. And now these machines also give us a waveform score. Just as we do multiple NCT evaluations or multiple attempts to get a pressure reading with an applanation, so does this machine. You need more than one measurement to be able to get you the ideal measurement. And the ideal measurement the machine analyzes and gives us a waveform score as well, because there are deviations which take place in any single assessment, and you need to select which is the best signal before you can take an analysis. So this is a normal signal, and you can see the parameters that I just spoke about. This is a signal with keratoconus, and you'll be surprised how repeatable this is. You can keep doing these patients again and again, and you'll get the same kind of pattern every time. This is what happens in Fuchs. The signals kind of move apart. They're also blunted with a lot of this thing, because this is a waterlogged cornea. It's waterlogged and thick, so the hysteresis is low, but the CRF isn't. Post LASIK, again the peaks move out. It follows a pretty much like a normal pattern, but it's just wider apart with a drop in CH and CRF values. Now there are two or three parameters really which are important. One is that the amount of force that we apply to any system doesn't necessarily mean it being the same. The resistance to that force may be different depending on the materials that is used. For example, if you use a piece of pine wood and apply a force, it will bend, but the same force may not apply to may not bend a piece of oak wood. And that's the problem with IOP algorithms that are based on thickness alone, because they're not looking at biomechanical factors, they're looking purely at thickness. The second thing where it's very useful is that in refractive surgery we have started to now look at a residual stromal bed and using that as our benchmark, but actually thickness is not strength, and there are corneas which may be soft, which may require a larger residual stromal thickness, and there are corneas that may be hard, which may be more tolerant and may allow more aggressive ablations. What are the normal values? These are some of the normal values of corneal hysteresis and corneal resistance factor. This is a distribution of keratoconus, normals and Fuchs. You can see this is the normals in the purple, and both the keratoconus population as well as the Fuchs population. One is thin corneas, one is thick corneas, are over to the left side. Last two slides, and this is a comparison between when we are looking at classifying corneal pathologies, is a look at the pentacam values. Now you look at group 3, these are normal corneas, normal K readings, just a spherical error, and the keratoconus indices on the pentacam come up saying they are normal. We take corneas which are thin and slightly higher myopia, and you find that a suspect reading comes up in about 13% of them on the Take patients with frank keratoconus, 100% of them will get picked up. But let's look at group 4. These are patients who have a keratoconus on one eye and a normal cornea on the other, and you see that the pentacam is calling them normal. Right? Now you take the same population and put them on the ORA. You will see group 3 normals being thrown up, the keratoconus match index, where the normal values are 1, and as the value goes down, you get severer and severer forms of keratoconus, and the keratoconus match probability. Like here, there's a patient with a KMI of 0.89. This is a 53% chance that this patient is a keratoconus suspect. This is what happens in pre-cross-linking. Patient of keratoconus, mild keratoconus with a value of 0.02. And this is what happens post cross-linking. A year later, the values have improved to 0.3. So there is some biomechanical evidence to suggest that cross-linking actually works. These are the clinical applications of this technology, wherein we're looking at pre-op ectasia staining, we're looking at glaucoma diagnosis and screening for normal tension glaucomas, efficacy and post-LASIK IOP measurement. These are by far the only machines which give you an accurate intraocular pressure post-LASIK, where a lot of cornea has been removed. Thank you so much.